Okay, good morning, everybody. It's with great pleasure that I introduce Dr. Electra Paskett today for our Frontiers in Oncology presentation. I've known her for more than 30 years as a colleague and a really good friend. We've served on many boards together. She is president of both as president of the American Association of Preventive Oncology. She served after me as president, and we've served on many cancer center advisory boards. And also she serves on the NCI and NCAB, and I serve on the BSA. So we see each other quite often together on different committees. So Dr. Paskett received her doctorate in epidemiology from the University of Washington in Seattle, and she became the Marion Rowley Professor of Cancer Research at The Ohio State in 2002. She's currently the Division Director of Cancer Prevention and Control in the College of Medicine and Professor in the Division of Epidemiology and College of Public Health, Associate Director for Population Sciences and Program Leader of the Cancer Control Program. She's also the Associate Director for Diversity Enhancement Program at the James Cancer Hospital. Dr. Paskett is an internationally recognized leader in cancer prevention, survivorship, and health disparities in research in women's cancers. Dr. Paskett has been a primary investigator on the Women's Health Initiative trial and subsequent research on this study over many years. Her role has been focused on effects of aging and lifestyle factors on cancer survivors and breast cancer prevention and survivorship, as well as cardiovascular health in underserved populations. Her team has been examining recurrence and late effects of treatment and hope to provide information that could provide lives of breast cancer survivors. Dr. Paskett leads an NCI-funded multi-center PO1 examining why cervical cancer rates are higher in Appalachia, and she is the principal investigator of the Ohio Patient Navigator Research Program. Her research program is nationally recognized for studying cancer health disparities, and her research has evolved to utilize team science approaches to understanding intervening in cancer prevention, HPV vaccination, and promoting the use of early detection exams, improving access to diagnostic and treatment services, especially using patient navigation and survivorship. Her publications showcase her work in intervention research, and she's directed at cancer prevention and early detection and survivor issues, especially among underserved populations. She also has a diversity training supplement to the program project on cervical cancer prevention in Appalachia, and she has been at Ohio State, and she's mentored many trainees. She also has been involved in the Alliance Cooperative Group and serves as the director of the Clinical Trials in Oncology Cancer Control Program, and she serves as a multiple PI for the Alliance NCORE research base. In this national role, she's implemented successful programs to improve cancer screening and prevention and for underserved and minority populations to communities where screening has not been routinely available. She's been a critical leader of Alliance Cancer Control Program since 2011, and the group was founded by the merger of the American College of Surgeons, Oncology Group, Cancer, Leukemia Group B, and the North Central Treatment Group. She served as chair of the Alliance Health Disparities Committee and a multiple PI of the Alliance NCORE Research Group. She's she's a fellow of the American Association for the Advancement of Science, past president of American Society of Preventive Oncology, and she's been the former deputy director of cancer epidemiology, biomarkers, and prevention, and a section editor of Cancer. She's currently on as I mentioned, on the NCI NCAB, and when Electra speaks, people listen. And I have to say this is true. And she is on our EAB, and we are always listening to what Electra has to say. And so I'm really happy to present her today to give her her talk, and we're really excited to have her today.
Oh, thank
Thanks
you
so
so
much.
much. Thank you so much, Melissa. That was a really nice introduction. I always tell people just keep it short. I'm Electra, and I'm happy to be here today. And it's really nice to talk to you all. A couple of disclaimers or alerts before we start. Unfortunately, the people next door decided to install a patio, so I apologize if you hear the whatchamacallit, the round thing. They're cutting the bricks today. And I am recovering from COVID. And so my voice is not so great. And I might need to drink my hot tea along the way. But I'm real excited today to present to you really sort of a 20-year journey that we've conducted here at Ohio State. And Melissa mentioned the PO1 I have focusing on cervical cancer in Appalachia to try to understand and do something about elevated rates. And that's what we're going to talk about today. And first are my disclosures here. I do have some grants in the institution from Pfizer, Merck Foundation, and Genentech. And then Melissa mentioned some of my appointments. And the research I will discuss was funded by Merck, and then most of it was and is funded by the National Cancer Institute. So when I arrived in Ohio in 2002, this was the picture of cervical cancer mortality rates in white women in the United States. And you can see the red areas in Ohio. We love red as here at OSU, but this is not good. And most of Appalachia here. And so this picture really launched not 1,000 ships, but a really strong trajectory of research into understanding this. I always like to start by telling people where Appalachia is. Appalachia consists of 420 counties in 13 states, as you can see in the map. It is in 5 regions, but it goes from New York all the way down to Mississippi along the Appalachian mountain range. And the Appalachian Regional Commission was defined in 1965 in response to the region's deficits. About 8% of the total US population, or 24.8 million residents, live in Appalachia. Appalachia is both rural and has some urban areas. People think it's all rural, but it's not. There are some urban areas. It does have less racial diversity and higher rates of poverty, as well as lower education than the United States. And 78 Appalachian counties are considered economically distressed by the federal government. Appalachia is traditionally an underserved area in terms of healthcare, a lot of healthcare provider shortage areas. And cancer is the leading cause of death, along with heart disease. The factors contributing to health disparities include lower socioeconomic status, lack of medical care facilities and healthcare providers. For example, we have about 7 counties that have no mammography facility at all. Poor health behaviors such as higher rates of tobacco and obesity, and poor communication with health providers that's linked with lack of trust. So we were funded in 2003. We wrote the application in 2002, funded in 2003, from the first round of the Centers for Population Health and Health Disparities that has the tagline, Cells to Society, Overcoming Health Disparities. And this was a trans NIH initiative. In this initiative, we, the investigators, developed this model for analysis of population health and health disparities. And it's lovingly named, we nickname it the Warnke model after Dick Warnke, who led this paper. But we put forth that the reason we have health disparities is not just because of individual behaviors, but it is the interaction between upstream factors and downstream factors that cause health disparities. And if any of you were at AACR, there were models like this, sociological or socioecological models that were also discussed. And I wanted to give you an example so you can see how this model works. So the generic model is here on the left under model levels, and in the middle are sort of, I call the risk factors. And so what I'm going to tell you now on both sides has been conducted, has been proven in various studies. So we know, for example, we start at the bottom in the middle column, that Black women are more likely to have triple negative disease. We also know that they have lower rates of mammography or other preventive options, specifically lower uptake of genetic counseling and testing. And then you go up to the social relationships. We've seen that they have few positive role models for early detection because all the women they see are diagnosed later and die. Or role models for genetic testing. We go up to the social level. There's no or limited mammography treatment or genetic testing facilities located nearby. And go up one level more, poor quality mammography follow-up. And this was demonstrated, these two boxes were demonstrated in the Chicago Breast Cancer Task Force that explained the high rates of breast cancer mortality in the Black women who lived in the Southeast side. And then at the top, when you look at policy, states with no mammography genetic testing or treatment quality access assurance acts that exists today. So what can we do? What are some interventions that could work at these levels? And I want to tell you that the Chicago Breast Cancer Task Force actually tackled multiple of these levels at the same time. So they enacted legislation to assure access to genetic testing, quality treatment, and follow-up. They also had funding for navigators, and the navigators were put in the institutions where the mammography was done because in the past there was little or no follow-up. And they enforced this legislation so that the mammography facilities had to meet a certain quality assurance standard in order to get state CMS reimbursement. In our communities, I've already told you that we have 7 counties with no mammography. So we go with a mobile mammogram. We offer transportation to treatment. We have some Amish women in our counties that we transport if they have an abnormal mammogram. And I'm sure all of you have seen the resurgence of telemedicine and we use it at Ohio State now for genetic counseling and testing. Group-based education, peer navigation. Many studies have shown that effective, especially in our Black populations. Increased mammography, increased acceptance of genetic testing. We have a project in the field that's looking at this. And then, of course, if we could do genetic testing and counseling and testing, recommended surveillance, and then follow through on that, we could reduce the burden, the health disparity of Black women with breast cancer. So this is just a real example of what could be done. So let's focus back on our Center for Population Health and Health Disparities, which we call CARE. And I'm going to talk a little bit about the first 5 years and then the second 5 years. But our overall goal remains to understand why Appalachian Ohio women have high incidence and mortality rates for cervical cancer. So let's start with the first 5 years. Back when we wrote this in 2002, this is what we knew about cervical cancer. That smoking, lack of screening, back then we only had the Pap test, and HPV infection contributed to cervical cancer. This was before any of our vaccines. So that's what we focused on in our 3 projects. And at this time, there were 28 counties that were designated as part of Appalachia. We took the counties, divided them up into 4 regions. We selected both the urban counties in each region and randomly selected 2 rural counties in each region. The stars show you which counties we selected. And we went to those counties and we identified clinics that performed Pap tests. And then we conducted 3 research projects. So the first one I led, which was in those clinics, women who needed Pap tests. We randomized them to either receive a lay health advisor intervention or usual care. So the lay health advisor made 2 in-person visits to the women. The lay health advisor was from Appalachia. She then mailed materials to the woman based on her stage of change for accepting a Pap test, followed up with phone calls. And as lay health advisor, she really served as a navigator to assess the barriers and then helped resolve the barriers. Usual care women received a letter saying, oh, you need a pap test, please go see your doctor. And the women were in the program for 10 months. Here's the results by medical record review. This was what we wrote in the protocol. So this is per protocol. We saw an effect of the intervention wasn't significant, but we had a lot of missing medical records due to the health systems themselves. And so, in the same paper, we reported both the medical record and the self-report. So the truth is somewhere in between. And for self-report, we did have a statistically significant, almost twofold increase in uptake of PAP. So remember, all these women needed a PAP. The second project was led by my colleague, Marianne Weavers, and focused on smoking cessation. And so the same lay health advisor was trained to deliver a cessation protocol to women from the same clinics who were current smokers. And the protocol included behavioral counseling, nicotine replacement. The lay health advisor was supervised by a local nurse. And they were in for, again, 10-week period. The control arm, they received a signed letter from the provider saying, oh, you should quit. Please make an appointment so that we can discuss some treatment options. And by the way, here's some information on nicotine replacement therapy. These are the results. And you can see we had a significant effect on cotinine validated cessation rates at both 3 and 6 months. At 12 months, we had some women slip back to smoking, and more of the women in the control group quit. So the effect was not there at 12 months. The third project was led by Dr. Ruffin and looked at predictors of abnormal cervical cytology. So when women would come into those clinics, I mentioned that we recruited for a pap test, we recruited them to the study, and they filled out a questionnaire. And during the exam, we got an extra pap, a sample to test for HPV, and some bloods. And this is the prevalence of HPV we found. And you can see that any type, high risk, and type 6, 11, 16, and 18 were higher in our Appalachian population compared to US non-Hispanic white. And you can see that the last group is the types that were in the first HPV vaccine. Correlates of infection, younger women, current smokers, history of a prior abnormal, 5+ lifetime sexual partners, 2+ sexual partners in the last year. Nothing really surprising. So it kind of validated what we thought. So basically what we found in our first 5 years was in the background of the Appalachian culture, which I explained a little bit early on to you. We saw abnormal pap test rates were elevated and high smoking prevalence. You'll hear more about smoking prevalence, but I can tell you in the women with abnormal PAPs, the smoking prevalence was about 68%. Higher HPV rates, I showed you, we already talked about higher poverty. We're going to talk a little more about risky sexual behaviors. And we saw high rates of depression, which we'll talk about a little more. We did the CSD screen. At the same time, we have low access to healthcare and low trust in healthcare providers. So just kind of a recap. And then that led us to apply for our second 5 years of funding, which we were successful in obtaining. And when we proposed this, we took the Warnicki model and we just turned it on its side and proposed these 4 projects across, again, the model from biology to policy. Project 1 is achieve environment interaction. Project 2, social networks in smoking cessation. And Project 3 was our psychoneuroimmunology project. And Project 4 was our intervention project to look to see if we could activate patients and providers to increase the uptake of the HPV vaccine. So now I'm going to briefly go through these projects and their results. So Project 1 was led by my colleague, Chris Weghorst, who is a molecular biologist. So I, as an epidemiologist, are just going to briefly explain the results. So the goal of this study was to determine the role of heritable and somatically acquired genetic alterations in relation to key components of the TGF-beta receptor complex. whose variant forms are established cancer susceptibility alleles or associated with cancer development. So Chris got this idea by looking at cervical cancer samples from women in Kansas. And he thought, let's compare it to Appalachia. Could that explain the elevated rates? And he got some good pilot data, which really fueled this study. And as I mentioned, TGF-beta is frequently altered in human cancers. And there are some polymorphic variants, SNPs, and Chris was specifically interested in the 6A allele, which is what he did the pilot work on. So he conducted a case control study to examine the association between genotypes and cancer status. So in the case control study, we needed cases, and we went all over Appalachia to get some cervical cancer cases. You can see we went to Kentucky and West Virginia, and some healthy controls, got blood, buccal swab, HPV tests, and questionnaires. Used the same questionnaire that we had in Care 1, and we had about 729 healthy controls left over from Care 1 that he used, which really allowed him to conduct this analysis. So the first finding is for TGF-beta 1. This is a ligand for the pathway. It's a SNP in the promoter region. And he found an interaction of smoking by status by genotype that was statistically significant, in that the homozygous never smokers had a protective effect. Again, these are cases versus controls, and this is the odds of being a case. Then another result was looking at P53, which is responsible for apoptosis and cell cycle in cervical cancer. Again, an interaction of smoking status by genotype, statistically significant. But this time, the GG never smokers had a higher risk, a threefold increased risk or increased odds of being a case. So, and this is where the test is going to come in. There's going to be a little quiz at the end of this. So pay attention to the boxes. So what explains the prevalence of genetic polymorphism is could these genetic mechanisms explain why we see cervical cancer in non-smokers? Second project led by Dr. Wewers, and her question was, we know tobacco is a putative risk factor for cervical cancer. And in Ohio, the smoking prevalence is in women is 28%, but in Ohio, Appalachian women, it's higher, as I mentioned earlier, 32%. So Dr. Weaver's got this idea from the first study where she found that women who smoked tend to gravitate with other people who smoke, and they had more isolated social networks. So the goal really here was to characterize social networks by smoking status, never, former, and current. And a little bit about social networks. So you think of yourself here in the middle as the ego. You have friends, which are called alters, and sometimes the friends know each other, as indicated by the green arrows. So she looked at, again, a multi-level model, the association between smoking status and these various levels, including social networks. So this was done by a cross-sectional survey. Most were conducted in the participant's home on a RedCap server. This was our sample, about 400 women. You can see the age range, 18 to 95. Most had health coverage, 20% current smoker, 22% former smoker. She didn't do cotinine verification, so I'm not sure how reliable our self-reports are. And the median household income, you can see, was in the 40,000 range. You can see that about 17% scored high on the CASD, indicative of a need for further follow-up or depression. So I'm not going to go through all of these data, but at the top, these are the odds of former versus current, odds of never versus current. And you can see, for example, at the individual level, 1 unit increase an age more likely to be a former or a never smoker compared to current, and current smokers tended to have more depression. Just example there. But she did find in terms of your social network right here, and she divided it into time network and advice network, meaning people who you spend time with, and this advice network are people who you seek advice from. So we have different networks, those who we hang around with and those who we seek advice. And they were both related to smoking status. And again, here, percent ties who smoke in the advice network, the higher, the more likely to be a current smoker. So yes, there was a relationship between tobacco use and your social network, social influences, and social cohesion at the social physical context level, as well as depression and age. And so Dr. Weavers would like to develop intervention using social networks, and that still, I think, is in the future to work on. So tobacco use, we know, is a carcinogen. We've seen genetics. Could that be responsible among non-smokers? Now let's talk about HPV vaccine, because HPV. Because when we did our first round, we didn't have a vaccine. But when we did that study, the vaccine came out in 2006, and we got some anecdotes, and we did some focus groups, and we were started to be really worried about A, the uptake of the vaccine, but B, the efficacy of the vaccine. And as I showed you before, we know that women in Appalachia have a higher rate of this high risk HPV. And why were we worried about the efficacy? Well, that brought us to this Project 3, which looked at HPV immunization response and stress, because we were worried about stress. So more and more now, stress is being recognized, and actually a validated thing, that it affects our health. It gets under the skin and actually can be related to cancer. And if you have access to AACR, the presidential symposium that was held, Dave Tuvison did a really nice symposium that talked about stress and cancer, all the way from the cellular level to what I spoke on, disclosure here, at the population level. So if you have time, you should look at it. But anyway, so we know at the psychosocial resources, they're lacking in Appalachia. Socioeconomic status, healthcare access, I've talked about this. We found that there's low social support, high feelings of loneliness. We thought that they might have an Appalachian self-identity similar to what our Hispanic or our Latino populations have. No, only, you'll see some data, but only about a third recognize that they're Appalachian. And we also, Dr. Ruffin also found very poor coping strategies. So that all, contributes to perceived stress. And first of all, how do we cope with stress? Well, they cope with increased smoking, increased alcohol use, which causes more depressive symptoms, as well as the stress. And all of this side causes, as well as the stress, causes immune dysregulation. This is what we were worried about. The other side, another way to cope with the stressful behaviors and the perceived stress is risky sexual behaviors, which we found in terms of increased numbers of partners, less condom use, and causing a history of abnormal PAP, which led us to say this risky behavior is increasing HPV exposure multiple times, and can lead to infection, and it's the persistence that causes cervical cancer. So this is what we were afraid of, that with all this stress and the immune dysregulation, that if we gave the women the vaccine, that there would not be this antibody change to protect them against this because of this immune dysregulation. And that's the whole hypothesis of this study. So we recruited women up to age 26, 18 to 26. You can see the mean age. Most of them were white, which is typical of Appalachia, as I showed you early on. Most were single. And let's go here. Only 39% self-identified as Appalachian. 4% had never had sex, and the mean sexual partners was 6.5. Age of first intercourse, 16. 26% were current smokers, 72% drink alcohol. Of those who drink alcohol, 49% reported binge drinking in the last month. So go back to that model I just showed you. All of these are popping up. We've also got drug use and obesity, and 30% have a prior abnormal pap. So first of all, we designed the model and we recruited this sample of young women, and the sample is validating the model, except let's look at the part we were afraid of. So the mean perceived stress was 23.5, and I can tell you, if those of you are worried, we got a very nice distribution of stress. We were worried it was going to be on one side or the other, but it was a really nice distribution. And the median's CSD screener for depression was 9, but those who scored at 16 or higher, which is indicative of clinical depression, 28%. So again, validates our model. So at baseline, we did cervical HPV DNA, 50% negative, and we also took blood, as I told you, and when we were interested in we worked with the Glazers to look at reactivation of EBV as a measure of their immune function. And, these are the distributions here. So what did we find? What was the impact of HPV 18 of perceived stress? A 10-unit increase resulted in a 22% decrease in their titer change, which is not clinically significant. Yay, we can breathe again. The impact on HPV 16, only factor that impacted was the number of lifetime sexual partners, 4 or greater. You saw a 60% higher titer change. No other variables impacted titer. So we were very relieved to be able to say that, yes, the vaccine will work in Appalachia. So these are all the boxes now in our model that we looked at in Project 3. So Project 4 was the intervention project, and this one we wanted to develop and then evaluate a multi-level HPV vaccine intervention to increase HPV vaccination rates among young girls in Appalachia. And at the time we did the study, the vaccine was only approved for girls. So the levels were parents, healthcare providers, and health departments. And we tested this in 6 counties, and then we did a control, and our counties don't like to get nothing. And so we developed a parallel intervention where the content focused on the flu and the flu vaccine. So what were the results? I like to tell the story. My statistician called me and he said, Electra, I have good news and bad news. I said, what's the good news? He said, yes, statistically significant effect. So you can see that here at the first shot, 3 months, and the first shot, 6 months, statistically significant effect right here. And I said, well, what's the bad news? He says, very low. So remember, all these girls needed to get the vaccine, and we eventually got 13% in the intervention group to get vaccinated. And, after this, I've heard other presentations where they do randomized trials like we did, and usually they see a 7% difference, which is about what we saw. So secondary outcomes, who got their daughter vaccinated, parents who were older and worked full time, were the only 2 variables that came out. But, we asked them, why didn't you get vaccinated? Well, because my doctor said she didn't need it. Yes, she doesn't need it. That's why she's in the study. She didn't need it because she hadn't had sex. Yes, you're supposed to get the vaccine before you have sex. Oh, I don't want my mother told me not to vaccinate my child. So we heard a lot of this. And social influences, as well as socioeconomic status, influence getting the vaccine. Okay, now we're ready for the test. Can we put all the boxes together and create our own multi-level model to explain cervical cancer disparities in Appalachia? Ready for the test, everybody? This is what it looks like. So we created our own model, and this explains why there are cervical cancer disparities in Appalachia, all the way from biology up to social conditions and policy. So when I get here, first I want to thank everybody, and you can see over the 12 years we did this, it really took a village, as well as the clinics we worked with. But people say, okay, you did care 1, you did care 2. Do you have a care 3? And the answer is yes. We were funded. We're just starting our 3rd year, a PO1, and it's across 4 states with 4 universities: Ohio State, University of Virginia, University of Kentucky, and West Virginia University. And our goal is to address the burden of cervical cancer through the delivery of a clinic-based integrated prevention program that focuses on those 3 areas, still back from 2002. We know a lot more, but still back to 2002: tobacco smoking, HPV vaccination this time, and cervical cancer screening. And we are targeting individual, social, and community health system and broader contextual level barriers related to the burden of cervical cancer in Appalachia. Back to the model I just showed you. And again, we're doing this across the 4 states I mentioned. Actually, we are in 39 federally qualified health centers. So we're going to test the effectiveness of this program, and it's an implementation science study. So we will be looking at implementation, acceptability, bundling, which I'll talk a little bit about in a few slides, and then sustainability. And then, of course, our favorite wrinkle happened: COVID-19. What was the impact? Well, we had to delay starting phase 2, which I'll show you. We had to switch from all of our in-person training to telehealth. And also, actually, we took a break for about 3 to 4 months. We took a second break back at the end of last year, beginning of this year for Omicron. Our clinics lost staff, which had a really big impact on the viability of the clinics. This is our organization. So here are the MPIs at the top. We have an administrative core, survey, data collection, intervention, consortium, biostatistics, and evaluation. And then we have boards here. And these are the 3 programs, which I'm going to go into in just a second. This is another way to look at our organization. So, in a program project, all the projects use the cores. So then if you look at the institutional level, which is how this is delivered, we have our 4 universities, and they're responsible for working with the health system. So we have 10 health systems. Everybody has 2, we have 4. And so that the university is responsible for working with the health system to implement these 4, we call them initiatives in this prevention program. And what we did, we took our first year to really do a lot of qualitative interviews in our community. We got all the background of all of the counties we're in. We collected baseline data from the clinics, not only rates relative to these behaviors, but how many staff are there and things like that. And this is where we had to take our pause, our first pause right here, and then we rolled it out in the early intervention clinic. So 5 in the early intervention health systems. And data collection here is in the yellow. We're getting that from the electronic medical records. We have associates agreement with all of them, so we can directly go in and get the electronic health record data we need. The usual care was delayed the first year, and we actually took another pause here before introducing it into the late intervention clinics and introducing bundling here. So bundling, how we introduced it was all the interventions are sequentially introduced in each health system over a period of 9 months, like three months between them. And then what we wanted to do in bundling is teach them how then to work with all 3 of these initiatives in their clinic at the same time. And then we're going to look at sustainability, et cetera. So, in PO1s, you need synergy. So everybody focuses on these same themes. So quickly, let me go through the goals of the programs. The first one is Break Free. It's led by Roger Anderson and Amy Perkatich. And they want to test the effectiveness of a physician level intervention based on theory of planned behavior. And they also have a community health worker or a navigator at each health system to help women sign up and then stop smoking. I lead the second project, which is based on project 4 from the project I just talked about. I Vaccinate is what we call it here. It was the parent project. Now we're calling it I Vaccinate. And we want to increase the uptake of HPV vaccine. Our primary outcome is in children aged 11 to 12. And then we're doing catch up for 13 to 45 with shared decision making, teaching the clinicians how to do shared decision making for those 27 to 45. And then the third project is led by Paul Ryder and Myra Katz, and they're looking at cervical cancer screening and with the novel addition of male-based HPV self-testing. So theirs is a hybrid design, whereas, for example, mine is total implementation. So this is ongoing right now, the home initiative. They're all ongoing right now in the early clinics. We're just implementing them in the late interventions. But like in my head, I was thinking of bundling that, a woman comes in for an office visit and the electronic health record will tell the provider that the woman smokes, she needs a PAP, and oh, by the way, she has children who need the HPV vaccine and she's under 45. So there's an opportunity to do not only the multiple levels, but multiple generation intervention. And the provider can address all aspects of the program. But while we introduce them one at a time, now there's an example of a person who can get all three. And it's not, the burden is not all solely on the provider. We really divided up the role responsibilities across each health center so that they can decide how they're going to implement this. So again, we're just moving into bundling. It's being introduced kind of as a refresher of all the interventions and how to do the bundling. This is our evaluation framework. We're using the Proctor evaluation framework. And lastly, evaluation will be at the program level, the individual level, contextual variables, and then we have a cost effectiveness component led by Wendy Zhu and Eric Sieber that we will be able to look at cost effectiveness. So I'll be happy to answer any questions right now. Thank you for your attention, and Melissa's going to moderate the questions. So please raise your hand if you want to ask a question.
Okay, Melissa. There's somebody in the, oh yeah, please raise your hand. It was in the chat. Electra, that was an awesome presentation, and I love the whole circle of events of how you put everything together. It was just amazing, and you've done some incredible work over the last 20 years, especially with the PO1. And I think you mentioned this. So the HPV vaccine is not just for the girls, right? You're doing it for both males and females, correct?
Correct.
And then the one study where you did have just the females, there were both, because you mentioned the one component was including males. Is that right?
So our second study, CARE 2, it was only approved for girls at that time. Okay. So we only did that in girls. Now it's approved for girls and boys, and with the extended age range with shared decision making. I should say approved and recommended. So there's a difference between. Yeah.
Do you think you'll see a difference in terms of those the parents who will agree for their sons versus their daughters?
Do you mean more will have their sons vaccinated than their daughters?
Mm-hmm.
I don't know. It's interesting. The nice thing about doing this implementation science is we can go into a clinic and we can show them all the materials we have. I'm just talking about the vaccination project because that's what I'm over. Mm-hmm. We can show them all the materials we have, and it's kind of their library or their menu, and then they can decide, what they want to implement and how they want to implement it. So, for example, we designed these refrigerator magnets. They're about that big, and we said, here's some refrigerator magnets. You can use them however you want. If you can use it as a reminder for when to come back for the second vaccine or the third vaccine if the person's over 15 or older. So it's one health department that we're working with. They took them and they put them on every magnetic surface in their clinic to serve as a reminder, not just for the patient, but for them to recommend it. So, we're hearing lots of great anecdotes. We have a lot of qualitative work that we're doing. We have in the red cap, people are to write, any modifications, adaptations, any stops, anything that they're doing. So we're going to have a lot of data. But I really think this approach is really the right way, because we're teaching, the providers how to really make this part of their routine. And that's how it's going to, stay.
And it hasn't been part of the just the routine vaccinations for these kids?
Not so much. I mean, those of us who do research in the HPV vaccine, what we've heard is that the providers will say, okay, the 11 and 12-year-old well child visit, when they have to get the required vaccines, they'll say, okay, your child is due for vaccines. The Tdap and meningococcal are recommended. And oh, by the way, there's this new vaccine that you could consider. So immediately when you say new vaccine, the parent's like, oh, no, but it's not new. It was out in, I told you, all 2006. And so what we try, and this came from Noel Brewer, that he has this way that you introduce it, that the provider should say, okay, your child is due for 3 vaccinations, Tdap, HPV, and meningococcal. Do you have any questions? And so, you're given the facts, and we have educated the provider on the safety and the efficacy of the vaccine. We have provided tips for anybody who has questions about it, that they can, little talking points. We give them little talking points. And then we teach them, we've modified the 5 A's. If any of you know about the 5 A's for smoking cessation, we've modified that for HPV vaccination, and then the 5 R's if people are resistant at what you do. So we teach that to the providers. But it's a whole practice initiative, and they have their champions that sort of decide how they're going to roll this out, and they're the face in the clinic, not us telling them what to do.
And what's the frequency that you're recommending? 2 or 3?
2 or 3 shots. It's 15 and older get 3 shots. Under 15, it's 2 shots. Yeah, I know. Okay, so I'm supposed to say, because I received money from Merck, I have to say, okay. So yeah, I'm going to say something that's out of guidelines. All right. So many of you might have known that the WHO last week, actually the day that we did a panel on cervical cancer at AACR, recommended that 1 shot is good enough. And that has not been FDA approved yet. So I am not advocating for that. I am just reporting what was put out by WHO.
Well, I'm only saying that because Doug was a speaker here not too long ago.
Yeah. So Doug Lowy says exactly the same thing that I do, because I heard him present at AACR and said the same thing. So, I mean, it might go to FDA to see if we can get it to 1 shot. That's been Doug's goal for a long time, and I think that will be superb. The other thing I want to mention that's at the FDA that we haven't heard, and I'm very upset about this, is the self-testing. So self-testing for HPV is used in other countries. It's not approved in the United States by the FDA. And it did go before the FDA for emergency use authorization during COVID, and it's still sitting there. So that's 2 years it's sitting there. And so Myra and Paul are doing this study, and because it's not approved by the FDA, the IRB requires a letter be sent by the provider to women who need a PAP, inviting them to come in to get a PAP. If they don't come in within 6 months, then Paul and Myra can put the woman in the study and mail the self-test. So another thing in this country that, okay, I'm being bold right now. I think it's very discriminatory toward women's health that we don't have the self-test approved by FDA, but it's approved in other countries.
We tested it in Mexican Americans in Houston, and it worked really well. And
right.
So I'm surprised it hasn't yet been approved.
Right. Not only women, but marginalized populations, who don't feel comfortable or can't come into, the health systems. It really works. The women do it.
And we do it. I mean, we actually did it in the Mexican consulate. I mean, and passed it out. I mean, it was a really successful project.
Women do it. And Paul and Myra have published from their pilot study. And, we can get women to do it. And the problem is you have to assure follow-up. And so in their study in the PO1, they're training somebody at each of the health centers to be a navigator who can follow up with the positives. So that you have to have that piece. Yeah.
Correct. Are there questions? I mean, I feel like I haven't seen anything come up in the Q&A or any hands raised, but I can't see hands. So Maria, have you seen any hands being raised?
Not yet.
Well, can we ask people to come up and ask some questions? This is usually a very vocal group, so I'm surprised we haven't had any questions, and especially with a talk like this, I'm very surprised we haven't had any questions. This is very unusual, Electra.
Oh, what can I say?
I don't know, but it's been a very provocative talk, and I wanted to thank you again, especially under the conditions that you have right now. I'm not feeling well, so I really want to thank you for this. So
thank you very much for the invitation. I always like speaking about this project. I'm very passionate about it.
Well, it's pretty clear that you are.
Yep, working in this area for a long time. So, yep.
Was there anything, and nobody else has any questions or comments or thoughts or anything? Electra, I don't want to keep you any longer if no one else is going to ask. I can talk to you anytime, which I do.
Know.
And so I can ask you lots of questions and we don't have to keep this dialogue going.
One question.
Oh, we have a question. Okay. Elise.
Oh, Elise, hello.
Can we take you off mute?
Go. Can you?
There we go. Okay? Hi, Elise.
Wonderful. Hi. Thank you so much, Electra. This has just been amazing. I'm really absorbing everything that you said. Incredibly insightful and really inspiring for us, particularly as we're starting to build out some of our community outreach and engagement work. And in particular, one area that we do need to address, and that I'm thinking hard about how we do that, is trust.
Yep.
So we have a very diverse community, and particularly in some of our communities, there is just a very clear lack of trust. And it's not with individual researchers. So the individual research projects, we have researchers who do an incredible job of building trust with their partners. However, trust in Stanford still isn't there. And I'm just sort of wondering if you have any general thoughts about that. I'm sure that you face similar issues where you are, but if you have any specific thoughts about how do you move from trust in individual researchers to trust in the institution?
Yeah, that's a really good question. We face this lack of trust. The women didn't have any trust in their healthcare providers. And we've worked in the communities over 20 years, as I said. And one thing that's enabled trust first in us is that when the grant ends, we don't go away. So we don't helicopter in and helicopter out. We also give back to the community. So, for example, we work with 6 community-based cancer coalitions in Appalachia. And we helped all of them become 501c3 organizations, and then they all write little grants. So we help them write little grants. We don't get a penny of that money. We help them, with about 50 grants over the time period, and $500,000. We don't get any. It all goes to them, and we help them, with their own agenda. And that really resonates, that they know that we are there for them and not for ourselves. And the thing we have in Ohio is that we are the institution of the state, and people out in Appalachia wear Ohio State hats and t-shirts because we are their university. And so that helps. But some of our other minority communities here in Columbus don't necessarily have the same level of trust, you would say. So we work really hard on that, and We try to navigate patients, and also we work internally. So, one of our biggest areas is people don't speak English. And so once we become aware of a problem, then, we know the places to contact to get the problem fixed. And that really helps build the trust with our community. So we act as advocates for the patients. And when we hear something, that shouldn't be happening, we take care of it, as well as educating, our providers. So it's an ongoing basis. You have to keep doing this, Elise.
Thank you so much. It's very helpful. We have been feeling like we need to do more building community capacity, right? Beyond sort of just working with communities, really building community capacity. And so it's very helpful to get examples of what that might look like. Thank you.
Thank you for the question, and thanks for the work that you do.
Thank you. Any more questions? Because we're just now about at the hour. All right. Thank you, Electra, so much. And we will be in touch and feel better.
Okay. Thanks.
Okay.
Everybody.
Thank you. Talk to you
Take
soon.
care. Yeah.
Okay.
Bye.
Bye-bye.